was able to walk and carry on with her life in an outpatient procedure. So most claudication responds to conservative management, but severe life-limiting claudication may benefit from revascularization. And it's well known that surgery has the best patency for this kind of problem, but it's not always possible because this patient population tends to have multiple comorbidities. In this case, an angioplasty and or stent may help, and the patency of something like this is about 80% at 5 years. So they can stay open for a fairly long time. But as a rule, many patients will come back for more than one intervention. So the next case is a 69-year-old female with severe left leg claudication. Again, a lifelong smoker, severe coronary disease, COPD, hypertension, dyslipidemia, and she was deemed to be a non-surgical candidate. And basically, this woman underwent a series of interventions over 2 years to try to manage disease of her SFA. So this is an SFA arteriogram, her left SFA. This is the distal femur here. And you can see there's this segment of the artery that's abnormal, multiple areas of stenoses. Her initial angioplasty was with a fancy device at the time we called a cryoplasty balloon, where we simultaneously froze and stretched the artery. And then she came back 2 months later, 3 months later, with severe, in fact, maybe even worse disease than she started with. So after that intervention, we placed a stent. You can see at the end of the stenting procedure, the artery looks pretty good. And that lasted for about 4 months. And she came back with the stent actually not looking too bad, but above the stent, severe stenosis. So we treated her again. She had another angioplasty. This picture over here looks pretty good. And then she came back in December, not too bad, but there's this intimal hyperplasia in the stent, and there's multiple areas of narrowing here, here, and here. So we treated her again. And she comes back 6 months later here, looking almost as bad as she ever did, and undergoes another intervention, after which she looks pretty good. And I think you get the picture. So finally, in February of 2011, she came for what has been her last intervention. So for about a year, she's been intervention-free, and we treated her with a new fancy device, which is a balloon for angioplasty that's coated with basically a chemotherapy drug. And the idea is that it prevents the intimal hyperplasia that you get when you do other interventions. And so far, we don't know what the long-term story will be, but at least over the last year, she's done much better than she had done for the prior 2 years. So the point of that case is I really want to point out that the SFA is sort of the Achilles heel of peripheral endovascular intervention and angioplasty. Almost everything we do has a very high technical success. So they walk out of the angio suite with an open artery, but they really do very poorly in the mid and long term. That has a lot to do with the anatomy of the SFA, and it undergoes a tremendous array of forces during bending of the knee and walking. So it can rotate, it can stretch, it can compress, and this basically makes almost everything we do doomed to fail. However, hopefully some of the new technologies like the drug-eluting stents show promise and will give us better patency over the long term. The next case is a 79-year-old male patient with bilateral leg and buttock claudication, Leriche syndrome, and his pain onset within about 1 block of walking. He has the typical comorbidities and the typical medications, but he has the additional complicating factor of having had previous open abdominal surgery and a subsequent ventral hernia repair, so quite a hostile abdomen for a surgical intervention. And what you see here on the left side, this is a 3D volume-rendered reconstruction of a CT angiogram, and what you see in particular is a very, very severe narrowing of his right common iliac artery. There is some disease on the left side, but you can't really appreciate it because there's this layering of calcium on top. And this is a coronal single slice from the same CT showing basically just a tiny trickle of flow passing through the origin of that right common iliac artery. So he was taken to the angiography suite for intervention. On the left side, we see an arteriogram performed actually from a catheter put in the left groin. You can see there is quite a severe stenosis of the left side as well, but the right side is just a pinprick or pinhole, and this huge, huge collateral artery, which is actually supplying flow around the stenotic segment. This is a picture from below the stenosis on the right side. You just see this tiny little trickle of flow going into the aorta. So in this location, we tend to treat these patients with a stent. So the pictures you see on the screen there are of a self-expanding stent. And what that means is it's a stent that goes into the body constrained inside a little plastic sheath. And as you pull back that plastic sheath, the stent basically starts to open on its own. And this picture down here gives you a sense of how flexible these things can be. This is basically tied in a knot and still open. And the idea of the stent is that at the end, it's like a little metal cage that basically props open the artery so it doesn't narrow back down. And so here's some pictures from the stent placement. 2 stents are kind of in position now. Then we put 2 angioplasty balloons up inside to stretch the stents up to their nominal size. And on the final angiogram, we call these kissing stents. And you can see that you've got great flow through both sides, no more of those stenoses, and that huge collateral that I pointed out to you before doesn't fill at all anymore. So all the flow is basically the way it should be down the common iliac arteries. So stenosis of the proximal common iliac artery is typically disease of the aortic bifurcation extending into those arteries. And usually we need to treat both sides, even though one side is only symptomatic. And that's done by either kissing balloon angioplasty or, as you see here, kissing balloon stent placement. And this has quite good long-term patency and is often done because surgery is not possible for multiple comorbidities. The next case is a 47-year-old female patient who has hypertension, congestive heart failure, and renal failure. And she's in this brittle physiologic state where if you hydrate her enough to provide enough perfusion pressure to her kidney, she's in heart failure. And if you diurese her, she doesn't have enough perfusion pressure to her kidney, and she's in renal failure. She has, again, the usual comorbidities. She has some right leg claudication, but she has the additional complicating factor of only having one kidney because she's had previous right nephrectomy. So this is a very good patient to have she needs renal artery revascularization, and she would hopefully get a renal stent. So this is a patient this is an MR angiogram. Here's the aorta. Here's the tiny little stump of the right renal artery. There's the left renal artery, and you can see here it actually almost looks occluded, but that's an artifact of MR. It just means it's very, very highly stenotic. Here's the conventional abdominal aortogram, which basically shows the same thing, a severe focal stenosis of the proximal left renal artery and a particularly severe stenosis about 2 centimeters beyond the origin. And here's the selective left renal arteriogram. So we've now managed to place a catheter into the origin of the artery and repeat it. You get the sense there's a little bit of a shadow on the bottom of the vessel here, and that's a big piece of calcium basically, which is the cause of the problem. And so in this setting, because of the calcification, we would place what's called the balloon expandable stent. So here's a picture of a balloon expandable stent. You've got the stent crimped down onto an angioplasty balloon. As the balloon inflates, it opens at either end first to kind of tack down the ends of the stent. And when the stent is fully inflated, or the balloon is fully inflated, the stent is fully expanded, and it will keep the artery open, as I showed you in this picture, which you've already seen. And here's the post and the stenting result, and you can see that the left renal artery is widely open. You do see, again, that little shadow of calcium that's now been pushed off to the side, and so flow can go through the renal artery. So only a tiny fraction of hypertensive patients actually have renal artery stenosis, and most of them can be just managed medically even still. It should be suspected when you see a patient with severe or refractory hypertension, acute renal failure that onsets after initiation of an ACE inhibitor or angiotensin receptor blocker, or patients who have recurrent flash pulmonary edema. The results of stent placement are quite mixed, so about a third of patients get better, a third stay the same, and a third get worse. But a patient like this is really the perfect patient for renal revascularization. The next case is getting a bit more advanced. So this is a 65-year-old patient with severe right leg claudication. The usual history, the usual meds. He has no previous surgical history, and on examination, he has a decreased right femoral pulse. He had an arterial Doppler study which showed a dampened waveform in the right leg, in the right common femoral artery, and the ankle brachial index on the right side was 0.6. This is a bit of an older case, so we actually don't have any non-invasive CT or MR for the diagnosis. He had a conventional diagnostic arteriogram. And what it shows you is probably best outlined on this picture on this side. We've introduced a catheter from the left groin. We've done a pelvic angiogram. And you can see there's a segment of the right external artery that's completely missing, completely occluded. You can see these collateral vessels here bypassing the occlusion and reconstituting the common femoral artery distally. But you can see how sluggish the flow is because everywhere else everything is quite dark. And down here there's not very good density inside that artery, which tells you that the flow through there is quite slow. So what we went on to do is we went on to try to recanalize that. So with sort of more modern techniques and technology, we actually have the ability to reopen a completely occluded artery. And so here what we have is from the left side, we've introduced a catheter, and the tip of that catheter is in the right common iliac artery, and that's how we did our angiogram. And if you look very carefully at this picture, you can see there's a little ghost of another catheter that's been introduced to the right groin. It's passing up here along my arrow, and you can see the tip of it kind of projecting over the lumen of the common iliac artery. But I can tell you that this was not inside the common iliac artery, it was outside. And we've traveled in what's called the subintimal plane. So we've basically gone beneath the intima of the artery, but inside the adventitia, and tracked through there to get past the occlusion. And here's an example of where some technology really helped us because we were unable to get a wire or anything back into the actual lumen of the artery. So now we have this thing we call a reentry catheter. So the schematic on this side shows this catheter in a subintimal space, and basically mounted inside that catheter is a little curved needle. So when you basically push the plunger on the back end, this little curved needle advances forward into the lumen of the artery, after which we can put a wire through and hopefully do angioplasty. And here's this thing in action. So this is this reentry catheter. This little L shape kind of shows you where the needle is going to go. And on this next picture, the needle's been thrown, and we've got a wire passing up into the common iliac artery. And once we've done that, it's back to what you've seen before. We can do an angioplasty to stretch it open. In this case, we put a stent to keep it open, and you can see now there's very nice flow all through that segment that was completely occluded before. So longer lesions and occlusions are most certainly harder to treat, but sort of more advanced technologies really allow us to do these kind of interventions that even 5 or 10 years ago would have been inconceivable. The next case is a 77-year-old male patient with a non-healing ulcer of their left great toe. Past medical history is important for type 1 diabetes, long-standing, chronic renal failure on dialysis, and of course coronary artery disease. On examination, they had normal femoral pulses and popliteal pulses, but no palpable pedal pulses. The Doppler study showed severe calcifications of the tibial arteries, which rendered the ABI invalid, but it showed dampened waveforms, so decreased flow in the tibial arteries. So here on the left side, this is a single picture from an MR angiogram and the corresponding digital subtraction angiogram. And basically, you've got this popliteal artery coming down through here, which is heavily diseased. You've got the anterior tibial artery here, which shows some areas of disease here and more disease here, but otherwise is actually pretty good going down to the foot. And similarly, you see multiple areas of stenosis and disease here in the proximal, posterior tibial, and perineal arteries. And the corresponding angiogram is the same. And in this case, what we were able to do through endovascular techniques is turn this picture here into this picture here. So basically, one by one, we crossed through those narrowed segments with a wire, put a skinny balloon over top and stretched it open, and the patient is left with what we call inline flow to the foot by all these arteries. You can't see it very well, but we ended up having to put a small stent here and also a small stent here, so we had to bail ourselves out in that way. And the important thing about this is that they healed their ulcer. So a critical limb ischemia is defined by rest pain, night pain, or tissue loss. Tissue loss. It's usually from stenosis or occlusions of the tibial arteries, so the distal vessels. And endovascular treatment is highly successful in restoring vessel patency and attaining what we call limb salvage, but it has terrible long-term patency. So we know that all these vessels will close, but we don't really mind because the goal is really wound healing, not a nice angiogram. So if we can open the arteries for long enough to get enough blood flow to the foot that the ulcer can heal or the rest pain goes away, we're usually happy. This is a case of a patient who has acute right foot pain. She's a 64-year-old female. She has the usual risk factors, but her important surgical history is that of a femoral to distal bypass graft placed about a year ago. And on exam, her foot was cool to the touch and pale, but she did have normal motor and sensory function, so she would have a viable foot. And so she came for an angiogram with a view towards doing something to restore flow in an endovascular way. These are a series of pictures from one angiogram. So this is the catheters in place from the left groin up and around to the right. And the right leg angiogram, you're looking here actually only at the profunda femoris artery. So the patient's native SFA and also the bypass graft are not seen at all. As you go further, you can see some attempted reconstitution of her popliteal artery and SFA via all these collaterals from the profunda, but really very poor flow going down to her foot. In this case, we were able to do something called thrombolysis. So through endovascular techniques, we can place a little catheter like I showed you, but this one has multiple side holes in it. And basically, if you put that inside the clot, you can infuse TPA through that catheter and directly into the clot, dissolve the thrombus, and restore flow. So here, it's a bit hard to see, but if you look, there's a tiny little dot there on at the femoral artery level, and there's the little thrombolysis catheter is tracking down here, and that catheter continues down to the knee, and the tip of it is in the open artery in the tibial arteries. And after about 24 hours of thrombolysis, you can now see that the graft is open. So this is the bypass graft, which you didn't see at all before, is now completely open, coming down to the foot. And you can see there's much better flow through this sort of single runoff vessel to the foot, which is the anterior tibial artery. So this saves an operation, this saves an amputation, and the patient continued to do well. The graft is still open. So endovascular techniques can be useful for acute ischemia, not just chronic ischemia. And usually if we can cross an artery or a graft with a wire and catheter, it can usually be reopened by thrombolysis. And we usually unmask what we call a culprit lesion. So there's usually a stenosis or something that's resulted in the thrombosis of the graft, and we can often fix it percutaneously once we've reopened it and gotten rid of all the clot. This is something a bit more dramatic. This is a 58-year-old female with a history of recurrent endometrial cancer after a previous total abdominal hysterectomy and bilateral salpingo-oophorectomy about 3 years ago. And she showed up to our emergency room with acute left lower quadrant, left flank pain, feeling dizzy, and having hematochezia. Otherwise, her past medical history was unremarkable, and she didn't take any medications. And on admission, she was a little bit unstable. So her heart rate was 115, her blood pressure was 90/60, and she had obvious left lower quadrant tenderness and a decreased left femoral pulse. So this is a CT scan done a year earlier. And what you can see here is that there's a big mass sort of in the left lower quadrant, which is in contact with her sigmoid colon here and her psoas muscle here, and encasing her left external iliac artery here. These are images from our CTA done at our institution, and the things that are important to see now, first of all around the external iliac artery here, there's all this gas and fluid, which looks like an abscess, looks infected. And within the large bowel, there's all this high-density material, which is actually contrast or blood. This is a movie from the angiogram that we did at the time of her clinical presentation. And basically, as it cycles through, what you can see here, this is her external iliac artery, and here's frank leakage of contrast right into her large bowel. So what we were able to do here is we were able to place a stent that actually has graft material on top of it and basically cover over the hole in the artery and basically keep flow down her external iliac artery and stop her hemorrhage. And basically this is the before and after photo. So here's the active leakage into her colon. The stent graft goes from here down to here, and there's no further extravasation. Now her story is not over yet, but the acute bleed was resolved and the patient survives to fight another day. So the take-home point there is that endovascular therapy is not just for opening of blocked arteries, and in the setting of prior malignancy and surgery, lower GI bleeds may be from unusual causes, not the usual things. And of course, an unstable patient needs to go straight to the emergency room for urgent evaluation and management. Got a couple more cases to go. This is a 70-year-old patient with incidental detection of bilateral popliteal artery aneurysms. Patient's totally asymptomatic from the perspective of this, although he does have some claudication. He has the usual history and risk factors, usual medications. And this is a CT angiogram done in the evaluation of this patient. This is the superficial femoral artery coming down the thigh here. And as you get to the level of around the knee joint, you can see this bulbous outpouching of the artery, which is a fusiform aneurysm in the popliteal artery, with a smaller one on the other side. Very common for them to be bilateral. This patient was not considered a surgical candidate, so it was elected to perform endovascular repair in this patient. So here's the angiogram before treatment, and here's the angiogram after treatment with a different variety of covered stent than the one I just showed you, and with complete exclusion of that popliteal artery aneurysm. The second stent goes by the brand name of Viabon, is significantly more flexible than the first stent that I showed you, so you can put it somewhere like a knee joint where there's all sorts of flexion and torsion and rotation, and hopefully it will stay open. And similar to everything else I've shown you, it's delivered on the shaft of a long catheter. You place this stent portion across the area of interest, and actually this is delivered by basically pulling this little thing, which is like pulling a ripcord, and releases the stent. So popliteal aneurysms are frequently bilateral. They're typically complicated by thrombosis or distal embolization, and unlike most other aneurysms, don't typically present with rupture. Repair is indicated when the aneurysm is symptomatic or more than 2 centimeters in diameter. And surgical or endovascular repair is possible, but it depends a bit on the clinical situation and the patient's comorbidities. Next case is a 61-year-old female with left leg claudication. This is a joint patient of myself and Dr. Oreopoulos. Her past medical history is important for a previous cardiac catheterization, which resulted in a left common femoral artery pseudoaneurysm. That was treated surgically. She's on no medications right now, but she had a life-threatening allergy to IV contrast, which we learned after we did this CT scan. And basically what you're looking at here is a 3D volume rendered picture of a CT angiogram. And the important finding, basically her arteries are quite normal. But as you come down the left side here, you see very, very early filling of her left common femoral vein, left external iliac vein, left common iliac vein, and her IVC. And these are enormous. They're way bigger than normal. And it's indicative of a fistula somewhere here between the artery and the vein. And it's not uncommon to have a fistula associated with the pseudoaneurysm in the setting of a cardiac catheterization. Now, because of her life-threatening contrast, Aljo, this is, yeah, that presents okay. She couldn't have IV iodinated contrast to do her angiogram, so we were able to do her angiogram and whole intervention with intraarterial carbon dioxide. And basically what you see here, you see the tip of a catheter that was introduced from the right groin, but the tip of it is in the external iliac artery. As we inject dye, we don't see the distal SFA at all, and we see prompt filling of the left common femoral and external iliac veins. And by placement of a covered stent, like I showed you before, basically now you can see that you have no further filling of that iliac vein, and you can see flow now actually going down the SFA. And she did really well. Her claudication resolved. I think that's the end. So I'll skip these last couple cases. And I'll just do a quick summary. So I hope I've shown that endovascular techniques are really indispensable in management of patients with peripheral vascular disease in 2011. And we have a wide variety of tools and techniques that are available to use, and each tool and technique is tailored to the specific clinical situation. Many procedures can replace surgery, especially in patients who are unfit for surgery, and advances in technology have really expanded the scope over the things that we can treat, particularly over the last 10 years or so. Thanks very much for your attention.
Is he going to use that?
He's going to plug his own in. He doesn't like using mine.
Plug it in. Is this some radiology thing that we have to have their own computers? Okay.
Stop the Lindsay stuff first.
Yeah, I know. I just want to make sure you're.
He's got the right. High definition. It's only the biggest one.
That should be good. Okay, good. And this is the keynote.
Okay, well, I think that what we tried to do last for the final talk is we're going to, Dr. Tan and I are going to, in the spirit of collaboration in which we work, we're going to do a little tandem talk here about complex endovascular therapy for thoracoabdominal aneurysms. And so, as a way of outline, there are three things that I want to actually leave you with. I want to talk about thoracoabdominal aneurysms and our abilities to try to reduce the complications of repair of these. We're going to talk about aortic dissection therapy, which is something that's relatively new. And we're going to talk about some evidence surrounding the critical role of post-EVAR follow-up. So, first thing is that you can see here that thoracoabdominal aneurysms only account for about 10% of all aortic aneurysms. And the reason these are different is the average infrarenal aneurysm occurs below the renal arteries. You can see all of these occur at or above the renal arteries, or they may include the infrarenal aorta. And these were initially classified by a fellow named Crawford from Texas, and this is his classification. And it's used surgically because these patients have a series of risks that you don't have with the infrarenal patients. So type 1, sort of from the left subclavian to about the level of the renal arteries. Type 2 can include the ascending aorta or just the entire abdominal aorta all the way to the aortic bifurcation. And 3 is sort of from the mid-thoracic aorta, and 4 from the level of the diaphragm. Now, the fact of the matter is, repairing these is probably one of the largest surgical procedures that's actually still done. And the problem is that the complications are significant. The magnitude of the procedure, here's just a thoracotomy with an open thoracotomy with a big thoracic aneurysm in the lung. But you can imagine an incision like this that goes right from the chest all the way down into the abdomen so that you can get to the level of the umbilicus, which is where the aortic bifurcation is. These patients experience significant complications, including spinal cord ischemia, because one of the major collaterals to the spinal cord usually comes off between T9 and L1. They also experience renal dysfunction, and that's because whenever you clamp this portion of the aorta, you make the kidneys ischemic as well as the liver and all the viscera, and those patients are very prone to develop multi-system organ failure. They also get pulmonary dysfunction because, one, you open the thoracotomy and you have to collapse the lung, usually to do the operation, and they usually have some pre-existing COPD. Obviously, myocardial infarction, stroke, and death are significant complications for these patients. So what have we been doing at UHN to try to reduce the risk for these patients? Well, I think we've shown you over the last couple of years, and Dr. Tan's going to show you an advanced EVAR case in just a minute, but we've been trying to do a proper preoperative assessment to try to predict and reduce these complications. So we do cardiac stress testing. We've now started to do imaging of the spinal cord blood flow, trying to localize the artery of Adamkiewicz, which is this collateral in the mid-thoracic to distal thoracic aorta, to try to predict which patients are going to be at highest risks. We localize the level of renal function. We all know that not all of the renal function will reside equally in both kidneys, and sometimes it's important for us to know whether the right kidney is contributing more or the left kidney is contributing more. We obviously do pulmonary function tests, and in the clinic we do this eyeball test. It's a very scientific thing, takes a long time to learn, but you have to really be prepared to look at these patients and say, are they going to be able to survive, and are they going to be able to recover from even a minimally invasive approach? Now let's just talk a little bit about spinal cord blood flow. This is a cross-section of the spinal cord. We're all well aware that the anterior two-thirds of the spinal cord is where the motor and sensory tracts are. But the blood supply of the spinal cord is segmental. You have blood supply that comes from the bottom. You have these critical arteries, the artery of Adamkiewicz, which you can see is imaged on MR, and here in the middle of the spinal canal you can see this artery. And this artery can be discontinuous, and it supplies a large component, the anterior two-thirds. There are two arteries on the posterior surface, and they tend not to be discontinuous, and that's the reason why many of the patients, they infarct the anterior two-thirds of their spinal cord, but that renders them paraplegic, often without bowel and bladder control. There is the conus, the distal portion of the spinal cord, is supplied by the lateral sacral branches from the internal iliac, and so we spend a lot of time evaluating these patients' arterial anatomy prior to considering doing these large procedures because we want to minimize their risk of spinal cord ischemia. There is a way to monitor spinal cord function. In fact, it's using motor evoked potentials where you stimulate the brain and you measure the response down in the leg. And because it has to go through the pyramidal tracts, which are the anterior two-thirds of the spinal cord, you can actually measure these, and people have started to do this in open thoracoabdominal surgery. We haven't yet done it at UHN, but because of the equipment that's required, you need an on-site technician, and they've got to be sitting next to the anesthetist telling them, hey, you got to raise the blood pressure and see if you can improve the perfusion to the spinal cord. Another thing that we do, another adjunct, is we drain spinal fluid. And of course, in a surgical procedure, you can actually reattach an intercostal to try to reperfuse the spinal cord. Now, we use something called cerebrospinal fluid drainage. And this is just a little picture of what happens. You put a catheter right into the spinal canal, and you attach it to a manometer. And the idea is when you drop the spinal cord perfusion pressure, there actually is a compensatory raise in the CSF pressure. And the arteries which have to cross the CSF can be compressed by this increased CSF pressure. So what do? We actually drain off the CSF to improve the perfusion to the spinal cord. And we have this in place before the surgery, and we leave it in place for 48 hours postoperatively. Now, the patients don't like it much because they can't sit up with this in, and we drain out this spinal fluid, and we found this to be a very important adjunct. We can raise or lower the level of the manometer, so if they start to develop symptoms of paraparesis or paraplegia, we can lower the level, and we've seen significant improvements over time, and that in conjunction with other therapies such as raising their blood pressure will in fact sometimes prevent these temporary dysfunction from becoming permanent. Now, I wanted to sort of highlight the importance of renal function, because what we do in our patients, as I mentioned, we do split renal function studies. It provides us with a GFR, and it localizes the site of the renal function. But in open thoracoabdominal aneurysm repair, renal function is a very big predictor of long-term survival. So those who have normal renal function, they certainly have significant mortality in the first little while after open surgery, but you can see that they have much better long-term survival compared to those who have impaired renal function, whose mortality in the 30 days after surgery is much higher and continues to be much higher. So renal function is an important predictor of outcome for these patients. Now, an important further adjunct in the perioperative period. Once we've sized a patient for an advanced endovascular intervention, we see them, they come to pre-admission, and we stop or reduce some of their blood pressure medications. We stop their ACE and ARBs, as the anesthetists generally want these stopped because it contributes to instability in surgery while they're having their anesthetic. I often reduce their calcium channel blockers, let their blood pressure get up to 140 or 150, but we obviously maintain their beta blockers to reduce their perioperative cardiac risk. We stop their clopidogrel because you can't put one of these spinal drains in to the spinal canal if they've been on clopidogrel because the risk of bleeding is so much higher, but we maintain them on aspirin. And even getting them to quit smoking for a month is an important adjunct. And just before I let Dr. Tan start about how we actually do this, because we do it as a team at UHN, the new innovation is that the company who makes these devices has now got an off-the-shelf device. And they've looked at thousands of CT scans, and they've built this device, which you can have on your shelf so that you can treat patients in an urgent fashion. And this is a schematic of the branches that they have. So there's a branch for the celiac, one for the SMA, and 2 branches for the renals. And you can see all of these little branches. So inside of here, there's a stent, and you can see the stent and the fabric here. And these are the extensions that we use that bridge between the branch here and the actual artery. And without further ado, I'm going to introduce my colleague, Dr. Tan, who's going to take you through a couple of cases.
Thank you, Tom. That was very nice. And so I'm going to show you some of the cases we have done, or one case we have done recently, the most recent endovascular repair for thoracoabdominal aneurysm. It was done in November last year. And a 75-year-old lady with hypertension on treatment, some cardiac disease, and she passed the eyeball test, as Tom mentioned earlier on. So she can proceed to the next stage. She has a 7-centimeter thoracoabdominal aortic aneurysm, as you can see if the cursor move right here. And it involves all the renals and visceral arteries. And this is a movie just showing you what this repair is about. It's much easier to explain this way. Here we go. We have the patients with the groin exposed, so we can see the femoral artery. The graph goes up. This is the custom graph we mentioned earlier on, or Dr. Lindsay mentioned earlier on. Very quickly, the graph deploy. Usually it's not that fast. It takes us about 4 to 12 hours to do one of these cases. And a lot of radiation time we have spent together. And here comes the second piece, going down to the iliac arteries. And then we put another extension on this side to the other iliac artery. And then we're going to do our arteriogram again to look for the arteries of interest, the renals, celiac, and SMA. So here you go. There's a diagram here, well, it's a cartoon, showing clearly that there's still a big leak because all these branches are not plugging into the other artery of interest yet. Usually we don't do it in this order, this diagram show. We usually do this piece and then followed by here, and then we build the infrarenal piece. So here we go. We have an incision here now on the arm or axillary artery. We pass the catheter up all the way down into the proximal aspect of the stent graft. And on average, in this case, it shows about 10 seconds to cannulate each of these arteries. We usually take about an hour for each artery. So 4 arteries means 4 hours just on doing the visceral and renal segment. And here you go. We put in a bridging stent. These are what we call the bridging stents. And we move on to the SMA. A lot of it depends on the anatomy of the patient. We spend an awful lot of time planning. I mean, the procedure is one part. The planning, the late night hours, we sit together in his office, looking at all these diagrams and making emails to Australia is quite significant to tell the planners how we want the holes to be cut, or how long is it, or where is it located. All this make a big difference to the procedure. And this is the last piece to the celiac. So this is 12-hour procedure in about 2.5 minutes. That's the longest we have, 12 hours. And we do a completion angiogram. Now you see all the branches inside now. So you remember the previous one, there was a leak. Now we have all the bridging stent into the arteries of interest, and now we don't have a leak into the aneurysm. So I must say UHN now has done the most number of advanced EVA in Canada. In total, I think the last count we have done close to 70 cases, and by far more than any other centers. Our team is working very well. We still have very few arteries that's lost, less than a handful. It means of one or two renals and celiacs. So I'm going to show you the real life of what the patients undergo. So this lady comes for, initially we have MRA. We identified, here you go, courtesy of Dr. Jaskoka here, the anterior spinal artery right there, the anterior midline structure here. So after that, we can plan the graft. We know that which level it comes in. In her case, it's T8. We try to adjust the graft so that we don't cover this artery. We have the split renal function. In her case, it's symmetrical. We have a GFR of 70 on the left and 72 on the right side. It's important that we sometimes, if the one kidney function is not that great, we try to save the good kidney first, and sometimes we lose kidney in these cases, so we have to concentrate which kidney to save. This is the plan for the lady, and you can see there are a lot of branches and a lot of measuring here. We measure all this position, we call it clock position. Once we know where to put all these branches, we email to the Australian guy who makes the graph, and these are the two upgoing branches for the renals and two downgoing for the SMA and celiac. This is not the actual graph for the patient, it's just an example. So once we have done that, Dr. Lindsay will sign the form and send it to Australia and pay the price. It's quite substantial. And this is the case itself. So this is an angiogram, lateral projection. I'll just show you where the SMA is. This is actually a fluoro record image of the graft being deployed. I'm just going to show you, this is the SMA branch. It pops open now. So we deploy the graft in a lateral projection. We identify the SMA. We know it's somewhere here. We want to make sure this piece is above the SMA. And these are the two renal branches pop open. Then once we have done that, I'm just going to show you one artery here. This is the left renal. 1 hour per artery, as I say. Here you go. We have a catheter going from below through the fenestration or through the branch into the aneurysm, and we inject some contrast, and you can see here is our target artery, the left renal artery, just a shadow of it here. And then we select the artery using a catheter of some sort, and after that we put a stent, and this is a comparison. You can see that the kidney is now perfused. You don't see the aneurysm filling in comparison to the picture here or the video here. So we now exclude the aneurysm. This was the last artery. The rest of them had already been stented. And after that, we do our completion angiogram. Hopefully show it here. Just to make sure that the aneurysm is excluded. Now you don't see the aneurysm anymore. You see the visceral and the renal arteries coming in. Here you go, there's a left and right renal, SMA, and celiac. And then we did a completion arteriogram before the patient goes home. And this is exactly as what we planned. We planned to land the stent graft right where the aorta kink. We don't want to land the stent graft above the kink because the graft doesn't sit very well. It's a very rigid device. And this patient did really well. And I think that's the end of the endovascular section. Thank you.
So if we can switch back, good. So we're going to talk a little bit about aortic dissection. Now, for many of you, aortic dissection probably doesn't come to your office as an acute problem, but it certainly comes to the emergency room as an acute problem. And you probably see these patients back in the office when they've actually had some sort of a repair. But essentially, aortic dissection is when there's an entry of blood into the aortic wall causing a false channel. And it's represented here in these 4 diagrams. And what happens is, instead of the aorta rupturing completely, the rupture occurs into the media of the wall, and blood travels down the medial wall and can create a complete false channel, as you see here. If it's a type A dissection, it involves the ascending aorta. And you can see it can either be a localized one right here, or it can be all the way down the aorta. In type B, they occur distal to the left subclavian, and they can either be localized or they can be the entire length of the aorta. Oftentimes in these types, there are multiple communications between the aorta, the true, and the false lumen. Now, the type A dissections, as probably all of you are aware, this is an acute cardiac surgical emergency, and as a general rule, these are treated with cardiac surgery because they can cause acute dissection and pick off a coronary artery, or they can have cardiac tamponade. So that generally these ones are treated surgically by our cardiac surgery colleagues. But these ones are treated as a general rule with antihypertensive therapy. Now, of course, the major consequences are rupture, or they can occlude major vessels, either to the brain, arm, bowel, leg, or kidney. And this is, in fact, a typical picture that we often see on a CT scan from where you can see the septum down the middle of the aorta, and one of these is the true and one of these is the false lumen. Now, as I said, the type A generally are treated with cardiac surgery, but there is an advance coming for an endovascular approach. With type B, blood pressure management has been shown to be the lowest risk short-term strategy, and we only use endovascular therapy for the failure of medical management, and that includes malperfusion of an organ, a major organ or a limb, continued expansion, continued pain, and failure to control the hypertension, actually. And here's just a little a cartoon of how an artery is occluded by this. So if this is the true lumen, you can see here this little branch, and when the pressure increases in the false lumen, it can pinch off this channel and result in malperfusion to the bowel, a leg, or a kidney. Now, the goals of therapy in type B dissection are really the acute relief of pain to prevent rupture and maintain organ perfusion. And here you can see a big type B dissection where there seems to be a flap, the first hole between the true and the false is here. There's a communication between the renal, and there's another communication here. And as I said, most of these are treated with antihypertensive therapy in the ICU, and then we get their blood pressure down. But in some situations, and in the chronic case, we're trying to prevent this false lumen from dilating because this isn't a full thickness aortic wall here. It's a little weakened, and it can grow with time. Now, if in fact these patients don't respond to medical management, sometimes we actually have to put what's called a dissection stent to cover over the initial tear, and this is a covered stent, but this part is entirely uncovered. And the idea is to try to expand the true lumen back against the false lumen, and then to plug the two communications, here, this one between the iliac and between the renal, with a covered stent. Now, there has been a lot of work done by something called the IRAD registry, which has identified the incidence of mortality for patients with type B aortic dissection. And here you can see this is the incidence of mortality in this patient population, and you can see the various factors. The recurrent pain has about a 25%. So if you get their pain under control and they have recurrent pain, then they can have a high chance of mortality if they have recurrent pain. If the pain is refractory, the mortality is as high as 50%. Obviously, rupture here up to 50%. This is if they have limb ischemia. Visceral ischemia is about a 20 or 30% mortality, and limb ischemia about 20%. So this is a brand new graft that's now available to treat type A dissection. It's a very short stent graft. You can see the various stents here and the fabric and the sutures holding them together. And this graft is designed to be deployed in a very specific manner. And that is, it doesn't just open up completely. Here's the sheath, and normally this sheath covers right up to the nose cone here. And so what happens is when you first deploy this, it only partially opens. You can see it's tethered here at the top, it's tethered at the bottom, and the middle part of the stent graft is actually tethered as well. So that you can put this up into the ascending aorta under fluoroscopic control. You open the first stent because you want to open it. You don't want the thing to recoil in this direction because you'll have to retrieve it. You want to open it here so that it opens in the right position. Then you have to hold it steady, and basically then you can pop it open. But notice it's still tethered at the back. And then the final step, once you're happy, if you wanted to bring it back a little bit, you could still pull it back a little bit from the groin, but the final step is to pull what we call these little trigger wires out here, and that opens the distal part of the stent. Now, Dr. Tan is now going to show us a case of some chronic dissections that we've treated at UHN.
Thank you, Tom. And 78-year-old lady with a previous ascending aorta repair for type A dissection, and there's still a type B dissection, and the false lumen where the aorta dissect was expanding at a fairly rapid rate to about 7.5 centimeter when she came to see Dr. Lindsay. So I'll show you a quick video here. Yeah. So just concentrate on this big, huge aorta. This is called the false lumen, where the artery or the aorta was dissected. This is the true lumen where all the contrast is. As you can see, that this thing is fairly massive, and it extends all the way down to the infrarenal aorta. Here you go again. And this is what it looks like on a coronal section. This is the true lumen, and this is the false lumen. And you barely see the entry tear in here. So what we planned was to put in a covered stent graft. So we have the wire actually going through from the right arm into the groin to allow us to actually push this device up over what we call a cheese wire or through and through wire to give it a lot of tension, and we push the device up. You can see the cone of the stent graft going to the innominate artery. We do an angiogram, and here you go. You can see the tear. This is at a very early stage of the angio, but on later stage, you can see it filling the entire false lumen. And then we deploy the stent graft, and immediately you can see that the false lumen or the entry tear is no longer present. We then complete our stenting all the way down to the infrarenal section. This is not a stent graft. This is just a conventional stent with no fabric to allow flows going into the visceral and renal arteries. In this case, you can see that after our completion angio, we have the left renal artery, but something is missing here. So the fabric or the dissection doesn't tack up nicely. So there's a malalignment of the holes or the fenestration. We're not perfusing the right kidney. We panic a little bit, but we have a solution for those things. It's called a renal stent. We put in a wire through the stent graft or to the stent interstices, go into the renal artery, and we do stenting. Now we can see the right renal artery. And this is the completion angiogram. A few weeks later, now we don't see any perfusion in the false lumen at the top end where the aneurysm is rapidly expanding. There's still some perfusion in the distal segment. All the renals and viscerals are perfusing. And over the time, and she actually had a follow-up more recently and showed that this thing remains stable. So there's no expansion of the false lumen over the last few months. And that's all for this case. Thank you.
So I think that these are novel treatments which, in fact, require complex care of, in fact, an interdisciplinary team. And I think it's really been actually our pleasure to be working together because it actually makes us share the stress and share the successes and occasionally the problems that we have. Now, the final thing I just want to share with you is follow-up care following any endovascular intervention. And by this, I really mean for aneurysms. We know that current aneurysm therapies don't prevent other arterial segments from developing aneurysms. So even if you do an open surgical repair, the old-fashioned type, obviously you repair the aneurysm that's there, but the rest of the aorta still has that mild connective tissue disease that predisposes those patients to develop other aneurysms, such as the one Dr. Jaskolka showed you in the popliteal artery, or sometimes in the iliac arteries. So previously untreated segments can dilate and result in late failures. And so the other thing that's become evident is that failure to adhere to the proper indication for the current devices has been shown to result in late failures. And this is an article that was published by some of our colleagues in the United States. And in the United States, there's a service called M2S, and you can send your CAT scan there and get them to measure an endograft for you. And they have, this group of investigators looked at over 10,000 patients who had at least a pre and at least one postoperative CT scan, and the average actually was 3 CAT scans. It was very interesting what they showed. They showed that about 59% of all of these patients had aneurysms less than 5.5 centimeters in men. And in fact, we don't believe that therapy of aneurysms less than 5.5 centimeters in men is in fact beneficial. So that was kind of a shocking finding. And then the second thing was that only 42% of the patients that had endovascular grafts implanted met the conservative instructions for use anatomy. So in other words, people were pushing the envelope left and right and showing that, and they were looking at the results of these. Now, if you use the liberal definition of the IFU anatomy, well, 69%. So it depends if you're a fiscal conservative or a liberal. Liberals are not in good shape in Canada at this moment. So, and what they showed was that the sac enlargement at 5 years was 41%. Now, we think of sac enlargement as a surrogate for some type of failure of the endograft. In other words, something's leaking there and the sac is continuing to enlarge. So 30% of those with sac enlargement did so not really early in their postoperative period, but only after 3 years of follow-up. And the enlargement rate was significantly higher in those who were treated outside the instructions for use. And so thus, follow-up for all EVAR procedures, even after 3 years when the patient doesn't necessarily want to continue to go for follow-up, is critically important. And I think that's a very important take-home message for all of us. So really, in conclusion, just to summarize the 3 points that Dr. Tan and I have tried to bring to you this afternoon, is that branched graft therapy is here. We're starting to move it into the aortic arch. We haven't yet done the ascending aorta, but those times are coming. Preoperative imaging is used, obviously, to prevent complications and to try to tailor our procedure to the patient. Motor evoked potentials monitoring is certainly something we're looking at, and we're hoping that that's going to help enhance our safety. There's a changing dynamic of aortic dissection therapy for chronic type Bs and acute type Bs, and maybe now for some type As. And the final point, follow-up in all EVAR cases really needs to be lifelong. The intervals differ for different patients, but I think that that's a critically important take-home message for all of your patients who we may have done that on. I'd like to close the session now and thank my colleagues for their talks and entertain any questions from all of you. So I know it's getting late. We tried to move things along here by canceling the last break. Peter's got a couple of, oh, he wants to know how complex aortic grafts are funded. Now, Peter, do you want the truth or do you want sort of... So the way it's actually complex aortic grafts, these things are expensive. Last year we talked about fenestrated aortic grafts. They run about $20,000. All in, a complicated 4-vessel branch can be as much as between $40,000 and $50,000. So some of those we've used innovation funding that the hospital supplies. We've also convinced the Ministry of Health, and so we have had some temporary funding for these. But it's kind of been, I would say it's been sporadic. We've managed to get them to spend some money for the last couple of years. So what I would say is not completely on solid ground yet, but I think that they begin to recognize you can have one of these patients go home in 4 or 5 days. Whereas if you've had an open thoracoabdominal aneurysm repair, it's a minimum 10 days to 2 week in hospital.
So just, Tom, I've got a question here about what specific non-steroidal meds, dose, frequency, and duration would you give for a patient with superficial thrombophlebitis? There's no real standard answer to this. I mean, it's really just an over-the-counter. I don't have any shares in any particular ibuprofen-based companies, but I just tell them to get an anti-inflammatory, and the dosage, is the standard dose on the package, and take it regularly is the key. And then the duration really depends on how quickly they respond to therapy. So a lot of it will depend on how severe someone's thrombophlebitis is. So it's just usually I'd put them on minimally for about 5 days and extend it out to 10 days if their symptoms don't settle down.
And Graham, how often do you use anticoagulation? Because we know that some patients with superficial thrombophlebitis actually have sort of occult DVTs. So have you been putting people, if they fail, on low molecular weight heparin, or what have you been doing?
I try and move them quite quickly. Often the ones I see are ones in large varicose veins. So once the acute situation is settled down, I bring them in, I duplex them, I know what their deep system is like, and I go ahead and try and book them for early surgery.
Okay, there's a question. This is for Dr. Tan and Dr. Jaskolka. How many chest X-ray equivalents is the radiation for a 12-hour closed aortic aneurysm repair?
Million?
Well, there will be probably a few hundreds. We usually wear radiation badges. So there's one outside, jotting out, outside our lead apron, and then there's one inside, beneath our lead apron. So it tells us what's the radiation we have. And last year, I still beneath the recommended dose, so I'm okay, despite many hours of fluoro time.
But what about the patient?
Sorry?
I say, what about the patient?
The patient should be fine. They're exposed to it only once. We are there every few weeks.
The other thing to make note of is these patients are typically much older patients, so yes, it's a significant radiation exposure, but all we are really worried about from that is the long-term effects of causing a radiation-induced malignancy that could ultimately kill somebody, and these people are old enough that it's almost not relevant for a single exposure like that.
All right, and George, tell us, so, what's it like to do, sort of you're half the time or 70% of the time you're on the vascular surgery floor and 30% you're in radiology, and has that really changed your perspective on how you treat patients both open and with interventional techniques?
I think it depends on the nature of the problem. In terms of peripheral vascular disease, we do a lot more tibial artery angioplasty than we used to, and a lot fewer bypasses. So it has changed my outlook, and many of these patients are older, frail, and even if the angioplasty lasts only a few months, as long as we can heal the wound and repeat it as necessary, once the metabolic demands of the foot are lower and the skin is intact, then I think that's a reasonable compromise. So I've tended to do fewer bypass operations as a result of my new experience.
All right, and Graham, tell us, you mentioned RFA and laser and how expensive they are. Now, apparently OTAC sort of, the Ontario Health Technology Assessment Committee said that, that this is now a recognized therapy, and so why is it that we don't offer it in OHIP covered service?
I'm only a blow-in from another jurisdiction, so Tom, I'll let you fend those political questions, because I know we applied to try and get this therapy at UHN to have paid by OHIP, but I'm not sure the ministry didn't seem to be that interested, and I don't know why. But
yeah, George?
I think at the end of the OTAC summary on EVLT, this was definitely a recommended therapy, one that would be appropriate. However, the caveat in the summary was that there was a concern from the ministry that there would be a much larger influx of patients seeking active treatment for their venous insufficiency than previously. So comparing the total numbers and the costs for the number of patients who undergo surgery, if it were strictly that number of patients, it would be a cost savings. However, if there was some concern that the number of patients could even quadruple, who would then agree to go ahead for treatment, and then the cost savings that they would have thought would have been lost.
Yeah, I think that, and so the principal advantages are what, though?
In the setting in Ontario right now, because I used to do some EVLT, in the setting right now, I believe it's recovery time, where patients are able to go back to work the same day or the following day. And individual patients' situation socially differs in terms of their work responsibilities and their income. And those patients for whom they would need to be back at work and it would be financially advantageous in a big way not to take the time off work, they've usually been the ones who've agreed to go ahead with the EVLT. There are some patients who desire a procedure where there is an ultimate cosmetic result. And we know that over the course of 2 months, the final appearance of the leg is achieved. It takes some time. 50% of them will still require some branches to be injected subsequently in a staged fashion. But it's essentially a scarless treatment in an office-based situation. And for some patients who desire really a cosmetic result at a different level, that's also an advantage. And then finally, we all have patients with chronic venous insufficiency who are really obese, and having a groin incision with a 6 times higher risk of wound infection in that body habitus can be avoided completely with with endovenous-based treatments. So the other thing that we've been doing at the UHN that Dr. Jaskolka has really pioneered based on his previous experiences is foam sclerotherapy in the interventional suite. And thus far, we've reserved this for patients who have severe skin problems. Dr. Roach-Nagel mentioned a small risk of neurologic events. In a recent review, this is 11,000 patients, there were 18 events.
Right.
Some of these were just migraines. So the risk is low. I think we're going to see a whole change in the paradigm of venous treatment going to an office or outpatient clinic-based approach outside of the operating room.
Okay, final question, because everybody wants to go home. Jeff, tell us about contrastless MR, and how can we get it? Is it really available, and is it really any good?
Okay, that's a big question. So contrastless MR has actually sort of been part of MR for essentially as long as MRs existed. So there've been the ability to image blood vessels with MR without contrast is one of the most exciting things about it for many, many years. But over time, we've learned that there are a lot of limitations to the standard non-contrast MR techniques, particularly in imaging the areas that we're really interested in, like the heart or the coronary arteries or the abdomen, where there's respiratory motion, cardiac motion. And the time it takes for those scans to get done basically makes it impossible to apply in those scenarios. So for many years, the standard of any MR angiography became this gadolinium-enhanced MR angiography, which was very fast, very robust, and had a lot of applications. And since we all felt that there was zero risk to patients from giving gadolinium, we would give it to all sorts of patients who had renal insufficiency, which were the people who typically couldn't have CT. More recently, we've learned that giving gadolinium to someone with renal insufficiency can cause a big problem in this condition called nephrogenic systemic fibrosis. So we had to really pull back from giving gadolinium in a huge patient population that we used to give it to, which was patients with renal failure. And that spurred a whole new interest in a whole new generation of non-contrast-based MR angiography techniques. And these ones are significantly better than the older techniques. But I would say that for the most part, my personal experience with them has been pretty disappointing. I focus more on the peripheral vasculature, and the pictures that I've seen at conferences and the pictures that I've seen in the MR manufacturers' handbooks are not the pictures that we produce on our magnet when we try it, with the exception of something that's brand new that we don't quite have our hands on, but it's an MR technique called KISS, or quiescent interval single-shot imaging, which we have our hands on sort of as a limited trial from Siemens, who makes it, and we hope that Health Canada will approve it so we can use it. So
you
in
think
general,
that,
it's
you think
not
that, but
quite...
that's for static areas, so it's not going to be for coronaries or areas with a lot of motion. It's going to be probably for distal circulation.
Correct. Now that Dr. Paul does a lot more cardiac imaging than I do. There are a couple of techniques that have shown promise in the coronary arteries as well, and some of them are kind of here. Like you can do pretty reasonable coronary imaging with a couple of the pulse sequences that we have if you both respiratory and cardiac gate.
Okay, perfect. If there are no other questions from the audience, we'll thank you all for attending, and Peter probably has the last word.
Thanks very much. I know everybody's tired, so two things. First of all, round of applause for these guys doing magic. I think you guys need to come up with a video game or something that, you know, like it looks like you're playing video games up there for 12 hours. So, don't forget to fill out your evaluation form. I am going to save my short summary, you know, the rapid fire that we usually do. I'm going to do it in the morning, so that way you'll get out of here so that you can beat the traffic, which is already bad. And so what we'll do is we'll resume tomorrow morning at 9 o'clock. And we'll have the quick summary in the morning, and then we'll go on with our whole day. So thank you to our whole surgical and radiology teams that we have here. Thanks very much. Thank you very much. Magic stuff.
Well, you know, I think it's about,
Magic stuff.
well, you know, it's all about trying to, you know.
I got a question. I know this is stupid, right?
Right.
Okay, 'cause